So this is the last part of the cataract series that we had. Anjori presented few topics, and this is the last part, which is post-operative complications following pediatric cataract surgery. So cataract surgery in a child is very challenging. It's not like we can't consider it like phaco in a miniaturized eye. Okay, it has its own unique set of challenges because the scleral rigidity is very high. They tend to have thicker corneas. Risk of trauma in children is very high. Even on the day of surgery, you try to open the patch, they try to resist and all that, and there's a chance of blunt trauma to the eye after surgery. Less compliance with activity restriction. All of us who have seen kids in the post-op period, we know how difficult it is to restrict their activities. And amblyopia is always one of the factors we need to keep in mind. So we classify complications, post-operative complications, into early onset and late onset complications. Okay, in the early onset complications, we have anterior uveitis, transient corneal edema, wound leak, and endophthalmitis. And in the post-op period, we have mainly capsule-related and lens-related, like visual axis opacities. These could be capsule bag opacification, secondary membrane formations, pupillary capture, deposits on the IOL decentration, and probably one of the most important, which is post-operative glaucoma, and some less common ones like retinal detachment, cystoid macular edema, and hemorrhagic retinopathy. Coming to the first one, anterior uveitis. We saw in the first slide about how anatomy of a child's eye is unique. So it's also with the tissue reactivity. Children's eyes are more reactive when compared to adults. Also, there is some manipulation that happens during surgery. There can be blood aqueous barrier disruption. There could be a reaction to the IOL material. Younger the age of surgery, more the chances of inflammation. There could be associated ocular or systemic conditions. For example, if it's a cataract that you're doing post-trauma, or if you're operating in a child who has rheumatoid arthritis, you're going to expect more inflammation. So in these cases, frequent topical steroids and even systemic steroids may need to be given. So how do we avoid this? Use as atraumatic surgical techniques as possible, and wherever you can, it has to be an in-the-bag IOL fixation. This is not a choice, but it is a mandate. Wherever possible, you have to put a lens in the bag. Unless, of course, you are dealing with a large lenticonus or something where you would put a 3-piece lens in the sulcus. The next one is the TAS, or the toxic anterior chamber segment syndrome. This is an acute severe inflammation that presents with diffuse corneal edema within 12 to 24 hours after cataract surgery. And to summarize why it happens, it's because it could be a reaction to the pH imbalance of solutions. It could be viscoelastics, certain intraocular medications that we have used. Ethylene oxide sterilized vitrectomy packs could be the other ones. So if you go through this paper, it beautifully tells you all the possible causes of TAS, right from the irrigating solutions, the visco devices that we use. There could be contaminants on the ophthalmic instruments of the detergent residues or bacterial lipopolysaccharides, denatured OVDs, that they could be very common, often overlooked causes of TAS. Sometimes ocular medications, you might use the incorrect drug concentration, incorrect pH, the wrong vehicle. Sometimes the make could itself be, if it's a new company, a local company which is very cheap and hence that has been used, then there's a risk of TAS. And less common ones nowadays, like polishing compounds of intraocular lenses and the cleaning and sterilizing compounds used for these lenses. What are the hallmarks of TAS? The typical hallmarks are it starts almost immediately. Within 12 to 48 hours after surgery, you would see inflammation. It is limited to the anterior segment of the eye. It is always gram and culture negative. Okay, and it improves with steroids. You'll normally see diffuse limbus to limbus corneal edema. Yeah, there could be hypopyon formation, fibrin formation, iris damage, and trabecular meshwork damage. So these are some of the images. So this is where you find diffuse corneal edema. You could have hypopyon formation, fibrin formation, and depending on the clinical features that you see, you can classify these into mild, moderate, and severe. A mild one typically clears with topical medications within a few days, maybe a few weeks. In moderate TAS, you could have more prolonged clearing inflammation, and the IOP could be raised for weeks to months. And in severe cases, it might be bad enough where you might have to do a corneal transplantation. You might have to also add glaucoma surgeries, and there could be significant iris and pupil damage after an episode of TAS. So how do you differentiate from infective endophthalmitis? One of the most important criteria is the timing of disease. So TAS normally appears within the first postoperative day, whereas endophthalmitis could appear anytime. It could appear early, it could appear a little later as well. TAS generally doesn't have any pain. There is no lid edema. Conjunctival congestion is minimal. The corneal edema is characteristically limbus to limbus edema. There are iris and pupil changes where you could have a fixed pupil and with diffuse iris atrophy. The pressure is always on the higher side. You don't get low pressure in a case of TAS, whereas you could get low pressure in the case of endophthalmitis. And there is dramatic response in TAS to topical steroids or oral steroids. Next in the series of early complications would be corneal edema. This is caused by irrigation fluids, toxic substances, extensive or excessive intraocular manipulations. If you are doing, say, a case of cataract with a lot of posterior synechia or post-trauma, then we do expect some amount of corneal edema. And if there's IOL touch during implantation. Another thing I can add to this list is also rubella cataracts. Normally, children with rubella do have some amount of corneal endotheliopathy. So after surgery, you could have transient corneal edema. Wound leak, something we don't see very often because we suture all the cases of pediatric cataracts, but it could lead to iris prolapse and increase the risk of endophthalmitis, apart from the fact that you have to take the child for a second GA very early, so best avoided. Coming to endophthalmitis, in the pediatric age group following cataract surgery, the incidence is quite low. It could be about 1:1,000 and the prevalence is about 7 in 10,000. The common organisms are Staph aureus, epidermidis and Streptococcus viridans, and the risk factors would be a missed NLDO, sometimes infections around the skin, around the orbit, and upper respiratory tract infections. URTIs, that's why we have to be very careful of when we are treating a child we're taking up a child for surgery. So what can be done to prevent this? You would have seen in the OT, all of us do this. That is a pre-op 5% betadine solution, correct draping techniques. Surgically, we need to make sure that it's very neat and very minimal tissue handling. Seal all ports and suture whenever you have a doubt. You have any doubt whether there's a wound leak or no, consider there's a wound leak and add an additional suture. The role of intracameral antibiotics is questionable. The benefits are not really very well established. So this is a paper by Dr. Rupal Trivedi who looked at subconjunctival versus intracameral injections, and while it is easier to give subconjunctival injections, the penetration is quite, you cannot judge the amount of penetration into the eye, whereas intraocular or intracameral injections, there is going to be full penetration. This is a very nice global perspective of pediatric cataract. These were all pediatric ophthalmologists who answered this questionnaire. This is a 32 questionnaire study. And from this study, what was the conclusion drawn was that 8 out of 237 respondents actually had cases of endophthalmitis. There were 22 cases of endophthalmitis. The age range was 2 months to 10 years. And in this, almost 1/3 of cases were children between 2 and 4 years of age. Whether you used an IOL, what type of IOL did not matter. You can see whether it's an acrylic, PMMA, silicone, all these cases had endophthalmitis. 2 cases did not undergo a PPCAV. So if we are under the concept that a notion that doing a PPCAV increases the risk of endoph, that's not actually true. The most common organism was Staph aureus, and 15 cases received an intracameral injection. So that's why I said intracameral injection, the role is questionable. Okay, it's best avoided because you're going to reduce the incidence of antibiotic resistance. So using pre-op techniques to make sure that you have draped properly, used betadine, selected the case properly, there's no infection in and around the eye, adnexa, that is more important than giving an intracameral injection. Coming to suture-related complications, again, this is a retrospective review which looked at whether Vicryl or Mercilin made any difference. There was one case of endophthalmitis in the Mercilin group, and in the Vicryl group, there was no suture-related complications. So Bainbridge and all had a study where they found that 10-0 Vicryl sutures, they actually maintained adequate tensile strength. It was associated with very minimum astigmatism, And it obviated the need for suture removal because it's self-explanatory. Vicryl is a suture which absorbs, and hence you don't have to post them for another GA for suture removal. So these are the early onset complications. Coming to the late onset complications, this is probably something we all face when we start doing pediatric cataracts, that is the visual axis opacification. In this group, the first one is capsular bag opacification. This includes opacification of the anterior, equatorial or the posterior capsule, and it is the most frequent complication following pediatric cataract surgery. You can get something as bad as this, where it often gets mistaken for a secondary cataract. It gets labeled, in fact, as a secondary cataract because it looks like a membranous cataract, whereas actually it's a visual axis opacity. So again, how do we avoid this? In most of pediatric, the complications that happen, these are avoidable if ideal steps are taken during surgery. So you make a nice big anterior capsulotomy, which is 5.5 to 6 mm in size, round and regular, and covering the optic of the IOL. So a large, which covers the optic. If you make a small capsular excess, what happens is generally there is a little bit of a shrinkage over time, or about 15% shrinkage over time, which can lead to capsular phimosis. It can lead to decensored IOLs and making retinal peripheral examination very difficult in the late postoperative period. The posterior capsular opacification, this occurs due to proliferation and migration of residual lens epithelial cells onto an intact posterior capsule. PCO rates are up to 100%. So if you don't do a PPC and AV, there's almost a 100% chance that this patient would end up with a posterior capsule opacification. Again, not only is it amblyogenic, but also requires a second surgery in form of a PPC and AV or a membranectomy. Coming to secondary membrane formations, now these can happen even after you have done a PPC and AV. These can occur due to inflammation. So inflammatory membranes can form in the pupillary area, which can grow either on the anterior or on the posterior surface of the IOL. So to reduce chance of this, you make sure that you are using optimal dose of steroids. So unlike the IATS study, so one of the flaws of the IATS study, which we quote so often, is that in IATS, the Predfort dosage was how much, fellows? IATS Predfort dosage was only 4 times. Okay, so they used it only 4 times. That's why if you read through that paper, you'll see that their complication rates were a little higher. We use high dose steroids. We give it nearly every hour. Okay, so that reduces the chances of inflammation. And any pre-existing intraocular inflammation that's there has to be controlled before you take up the child for surgery. So this is a small video of a child who had come from Bangladesh, and if you look at this picture, you'll feel as if there's a membranous cataract, but actually this was a case of a visual axis opacity which had formed, which needed membranectomy. Okay. So why I'm showing this video is that once the iris hooks are placed, you can see in the periphery, okay, that's called these are the lenticular epithelial cells. So this periphery that you see here, we call it the donut. This is it's a ring of opacification, the problem is if you don't clear it, membranes can form again and again. And the second thing is, what is the bigger risk of leaving this there? This ring, what can it do? Sorry? So this can actually go and later on close the angle. Okay, so it can push the iris up and eventually they could lead to angle closure and glaucoma. So that's why we should always clear this if you see it. It's easy to just go and clear the center and come out, finish the surgery in 5 minutes. But you have to actually clear that peripheral ring also. Okay. Dr. Jagatram has published this very nice paper where he says that it is not the type of lens that you use during surgery, but rather the management of the posterior capsule which determines the PCO rates. Okay, and that's what we have been seeing. Some of the other causes for visual axis opacity could be vitreous condensation and opacification. This can happen when early or in the first few surgeries that we do, either as fellows when we are learning surgery, or we are new into the field of pediatric ophthalmology. Sometimes we might do excessive iris manipulation, or the fear of doing a vitrectomy when the PC is open. We do a posterior capsulotomy. So while doing the vitrectomy, that fear that we have to place a lens again, we want to finish the surgery early. That time this happens. So we do an inadequate vitrectomy, excessive iris manipulation. In these cases, invariably the opacification develops over the vitreous phase that's remaining, because the vitreous acts like a scaffold. Okay. Vitreous incarceration into the wound and lens material mixing with the vitreous can also lead to vitreous condensation and opacification. Some of the other ones that we see are pupillary capture. This can occur in younger children when you use a very small sized optic and deposits on the IOL that we discussed, which could be due to inflammation and other pigments from the iris. These are not visually significant generally. IOL decentration can happen when we have not assessed either on table or just prior to surgery. So if we are trying to put a lens when the zonular support is very less, or we have put one haptic in the bag, one in the sulcus, we can get late decentrations. Coming to glaucoma, this is probably one of the most important of all the complications, because glaucoma can develop any time in a child after surgery. Okay, so we shouldn't be happy if we are seeing a 6-month post-op and everything is okay. It doesn't mean that this child is not going to develop glaucoma later. Why is that? We'll come to know. So glaucoma can happen both in aphakia and pseudophakia. The prevalence is reported to be as high as 41% depending upon the length of the follow-up. The reported time to diagnosis after surgery is up to 6 to 7 years. Okay, and this is backed up by other studies also. So in IATS, the secondary glaucoma rate was 8.8% at 1 year, whereas when the same cohort was followed up for 5 years, it was up to 17%. Okay. There are some other older studies also apart from IATS where you can see how high the glaucoma rates are. So what are the causes for glaucoma? Generally, the common causes would be open angle type, where it's a pre-existing open angle glaucoma, or there could be a steroid response. There could be vitreous in the AC, inflammation, rarer causes like ghost cell glaucoma or trabeculitis which can happen. But you could also have the closed angle type with or without pupillary block. So common causes for pupillary block could be that, again, the vitreous phase which is blocking the pupil. There could be a posterior capsule which is very thick and not allowing the communication between the anterior and posterior chambers, or the intraocular lens which is wrongly placed. You place a lens in the sulcus. I'll show you a case after this where a wrongly placed lens led to very bad glaucoma. And without pupillary block, it could be due to anterior synechia, prolonged AC shallowing, or iris incarceration in the surgical incision. This is a meta-analysis by some of the doyens in pediatric ophthalmology, where they showed something very, very important. So when surgery was done at 4 weeks or younger, the hazard ratio was higher. Okay, so if the surgery was done at 4 weeks or younger, these children tended to develop glaucoma. They also tended to develop glaucoma if there were additional procedures done. So you have done a cataract surgery, but after 3 months you did a membranectomy. These children would eventually develop glaucoma. And interestingly, primary implantation of IOL tended to have a lower rate of glaucoma in this meta-analysis. Okay, IOL is glaucoma neutral. So an IOL does not prevent or cause glaucoma if you have followed all the guidelines to place an IOL. But what is takeaway from this paper is very young age of surgery, chances of glaucoma are higher. Any additional surgery that you do, chances of glaucoma are higher. Okay. Anyone can tell me what does hazard ratio mean? So supposing this says 4 weeks or younger, HR is 2.1. Okay, so what it says, what it means actually is that if you have 2 children, one who's above 4 weeks of age, one who's less than 4 weeks of age, the child who's at 4 weeks of age has 2 times a higher risk of developing glaucoma compared to one who is older. Okay, so that's what hazard ratio means. Coming to the pupillary glaucoma, this can happen when there's significant amount of inflammation. There could be posterior synechia or poorly placed IOLs. Children are also uniquely susceptible to steroid-induced ocular hypertension and must be monitored in the post-operative period because we give higher doses in children. So we have to monitor their IOP every time. So this is the case I was talking about. I saw this case in 2017. What is wrong in this picture, the first picture? There's a pupillary block, we know. The IOL has moved forward. It is in front of the pupil area. Why has it happened? What type of lens is it? Okay. What is unique about the three-piece lens? Yeah. So what if it's implanted upside down? What happens? Correct. The three-piece lens has a vault. So if you flip it, it flips many times during surgery. You can reflip it during surgery. But if you leave it, it has a vault, and that because of that vault, the optic can move forward and cause this. So it had come beyond the pupil, caused a pupillary block. This was a 12-year-old girl. Her IOP was 45 millimeters of mercury. So what we did was we did a PI, surgical PI, and importantly, we did an IOL repositioning. So we flipped it back and put it in the sulcus. She continues to do well. She's finished. Last when I saw her, she had finished 4 years of follow-up, and at that time, thankfully, she was doing okay. So how do we manage these cases? Unfortunately, most cases require surgery, but there is a role for medications also. So you first treat them with medications, and if the pressure cannot be controlled at all, and if it is progressing, the glaucoma is progressing, the disc is showing changes, then we need to operate them. So question for you people would be, what is one of the signs for glaucoma? If a child has come in with glaucoma, what indicates? Myopic shift. So refraction, pay attention to the refraction, and especially to the first year PGs and all. Myopic shift need not necessarily mean the child has myopia. You could have a child who had, after surgery, a +4 glass, has come this time with a +1 glass. Okay, refraction is showing +1. Parents are very happy. Chashma utar gaya, jaane wala hai. Don't be happy when you see that. When you see a myopic shift, unless otherwise proved, it is glaucoma. So it's on us to make sure that it is a physiological myopic shift that has happened and not due to glaucoma. Okay. Coming to retinal detachment, the overall risk at 20 years is about 7%, and higher risk of RD is associated with other ocular and systemic diseases. We have an in-house publication, in fact, which tells us that when there's a 5.5 risk of retinal detachment the first 10 years after surgery, and this risk increases in males, in myopics, and those who are intellectually disabled, and if they have any other pre-existing issue in the retina, especially something like a PFV, persistent fetal vasculature, even these are prone to developing very aggressive RDs, so we need to monitor them. Cystoid macular edema, this is very rare. It's very rare to see cystoid macular edema, and you treat them like how you would treat an adult. You give topical steroids or NSAIDs and they resolve. Hemorrhagic retinopathy, again, very rare. Normally, you see hemorrhagic retinopathy due to the Valsalva maneuver. So when the child is coming out of GA due to breath holding and the change that happens, you could see a small bleed in the eye if you examine the posterior segment, but they clear on their own. They don't need any intervention. So this is another publication from India. You can see that if you look at the early postoperative complications, it's always the visual axis opacity related. Okay, it could be fibrin reaction on the IOL or a visual axis opacity. And the late complications, you could have posterior capsule opacification. So this is in brief about pediatric cataract complications. I would like to conclude by saying that complications are a part and parcel of a surgeon's career. So we shouldn't get disheartened if we have done everything to make sure that we are not responsible for that complication. Okay, so if we have taken all the steps, necessary steps, we can to only reduce the chances of complications, but it's never going to be zero. Pediatric eyes, as we saw, are uniquely susceptible to a few, okay, and especially glaucoma. That is something we need to really, really watch out for in the follow-up period. You need to meticulously examine and manage them very promptly when you see them, and many a time you need multi-subspecialty care. You might have to take help from retina colleagues, glaucoma colleagues, cornea, like that. So don't hesitate to take that subspecialty care. Okay.